amitriptyline, sertraline, fluoxetine. So in this presentation, we're going to talk about the indication, the principles of antidepressants, the classification, special cases, and also the serotonin syndrome. Here is another case, long story. A 27-year-old girl, Gelimabuza, female patient admitted at maternity ward 2 days ago because she injected a cocktail of drugs which included amoxicillin, vitamin C, prednisolone, and other unknown drugs because she had a conflict with a boyfriend of 5 years, in which they have 2 kids living together. The bone of contention is that the boyfriend is having another romantic affair. Then he decided, I need to die. She is referred to the psychiatric department for further management since her physical condition has stabilized now. Then during the counseling session, it was discovered that this was his second episode of self-destructive. So he once tried to kill herself. Then he survived about 2 years ago, where she ingested paraffin in a almost similar event. Then it was also discovered that she doesn't have much social support at home. All her relatives live in South Africa. She's unemployed, very dependent on the boyfriend. So she's just alone, no family. She complained of severe primary and secondary insomnia, which is failure to fall asleep and waking up earlier than expected. And he also have feelings of sadness, feelings of worthlessness, losing interest in cases where previously he was enjoying, has excessive appetite for food, also has anger tantrums. In our PHQ-9 assessment tool, it was discovered that she has a severe kind of depression, which means he needed antidepressants. During the psychotherapy, she was not given antidepressants. Why? Anyone who has an idea why she was not given any antidepressant? Severe depression, no antidepressants. Yes, she can take all of them, eat them at once. At the same time, this patient is coming from the maternity, he's pregnant. So the safety there. That is why she has to be seen within a short space of time of 3 days. Is there any question? No. The advantages and disadvantages of taking antidepressants, they are very good. They manage the symptoms of depression. They are very effective if you use the right drug. They are very safe if you use the right drug, even in pregnancy. But they can cause a lot of side effects, and it takes time to see the results, just like in antipsychotics. Some antidepressants may not work with other people. Antidepressants can be used in treating also many other conditions, not just depression, including anxiety disorders. They are the second line of treatment in as anti-anxiety medication. Can also be used in pain disorders, premenstrual dysmorphic disorder, although this one is considered an endocrine problem than a mood problem. We also use them in smoking cessation, in eating disorders, and there are also those off-label uses like for people who have incontinence and premature ejaculation. We use them for the side effects. They prolong ejaculation. So the principles of antidepressants, it's important to prescribe an effective antidepressant by prescribing it in an adequate dose, a sufficient period of time, not just short term, starting with a low dose possible to avoid the emergence of side effects, then titrating it up gradually, So you have to tell your patients that they are not going to see the antidepressant effect within a short space of time. It will take some few weeks for them to see the antidepressant effect, and they will have to take the medication for a long period, like 6 months or more. So they cannot take it less than that. Because if depression subsides and then you stop the medication, there's a high risk of relapse. Regular follow-ups are very important, especially because you combine antidepressants with psychotherapy. You cannot just give antidepressants alone. There has to be some counseling that goes with that. And gradual withdrawal of antidepressants is very important to avoid the withdrawal syndrome. Miss Lynn is going to take us in this slide.
Okay. Hello, I'm back again. Okay, this is about the mode of action of like SSRI, selective serotonin receptor reuptake inhibitor, and SNRI and TCA. Okay, actually this is quite simple. Okay, you can see that here is the synaptic cleft, and there will be a neurotransmitter like serotonin coming out. And there's also a receptor, a transporter on the cell membrane that is responsible for reuptaking the serotonin. So these agents, the SSRI, like fluoxetine, sertraline, we have them in the country. And also we have like fluvoxamine. I think we don't have this now, but they have the similar mode of action. Because this drug inhibits this transporter, so that the transporter will lose its function, so that more serotonin will remain in the synaptic cleft. So as a result, there will be more neurotransmitter, more serotonin available there. And for the amitriptyline, it has similar function. It also it's a tricyclic antidepressant, but it also inhibits the reuptake of serotonin. Okay, and this is some important side effects of antidepressant. Okay, as I mentioned here, you can see fluoxetine, sertraline, fluvoxamine for their mode of action. They target at they block the reuptake of serotonin. But for TCA, the tricyclic antidepressant, it not only inhibits the reuptake of serotonin, but it also inhibits the reuptake of norepinephrine. Okay, so it's more unspecific. And for the side effects, these agents they may have the side effects such as anticholinergic, sedation, orthostatic hypotension, and seizure. Actually, quite similar to the antipsychotics we have mentioned. But as you can see, the tricyclic antidepressants such as amitriptyline, it has higher incidence of these side effects compared to the selective serotonin reuptake inhibitors. Okay, and for the adverse effects, um, these antidepressants they may lead to suicidality in children or young adults, and may also lead to like insomnia, nausea, vomiting, and also serotonin syndromes. Okay, and also sexual dysfunction. Okay, this slide is about the drug interaction based on the liver enzyme. Okay, in this slide, there are many information on the slide, but the major point I would like to mention is that for the medication we mentioned today, including the antipsychotics and the antidepressants and even diazepam, uh, or even some other antileptic drugs such as carbamazepine, phenytoin, uh, phenobarbital. These agents they are largely metabolized by the liver. Yes, just like um, Edward has just mentioned about blood-brain barrier. Why these agents are able to cross the blood-brain barrier? It is because they are more lipophilic. they are more lipophilic, so they will be able to enter to cross this membrane, and also because they are more lipophilic, so it is also because of this characteristic. They are more lipophilic in their chemical properties, so that they are they are extensively metabolized by the liver. Okay, and many of them, okay, like the antipsychotics, they are metabolized by the liver enzyme CYP2D6. And for both the antidepressant and the anticholinergic, antipsychotic agents, and also some agents, some antipsychotics are metabolized by CYP1A2, and also like fluoxetine, sertraline, they are also metabolized by many different kinds of enzyme. Yeah, like CYP2C9, CYP2C19, 2D6. Anyway, so it means that they may have some interaction with other drugs, or even some drugs which are the enzyme inhibitors or inducers. For example, for the enzyme inducers, some of the very famous enzyme inducers include carbamazepine, phenytoin, phenobarbital, uh, and even cigarettes. Cigarette smoking is a inducer of the CYP1A2 enzyme, and also rifampin. Okay, these are the agents that we all know, we are all very familiar with in the country. And for the inhibitors, there are also many. Some antidepressants like fluoxetine, sertraline themselves are the enzyme inhibitors, and like the AIDS, the anti-HIV agents, the ritonavir is also an enzyme inhibitor, right? And also like the grape juice and also erythromycin, they are also enzyme inhibitors. Okay, this is just to give you a whole pictures. Of course, there are still other mechanisms other than the liver enzymes that may lead to drug interaction, and Edward will talk more about that later.
I'm finishing in 2 minutes 23 seconds if you count like me. Um, let's talk about the classification now. We have the tricyclics, which are very powerful, our most powerful antidepressants, but they are the older class. They have serious side effects. They may affect the heart, especially with people who have heart conditions. They can cause dizziness, drowsiness, dry mouth, weight gain, and they are very dangerous when taken in overdose. Which one amongst the three falls under this one? We have amitriptyline. Oh, amitriptyline, yes. So amitriptyline can be started with 25 milligrams in the night time because it's very sedative for 3 days. And then you increase after 3 days to 50 milligrams. Why? Why is it like that? You give it 25 milligrams for 3 days because we don't want to see the side effects first before we see the effect. And 25 milligrams amitriptyline has anti-anxiety effect, but antidepressant effect is noted at 50 milligrams. You can give up to 200 milligrams per day. Um, For the indications, when sedation is desired, if your patient has insomnia, you can give amitriptyline. In pregnant women, yeah, we can give this one. So it's the only one that can be given in pregnant women and breastfeeding mothers. The contraindications, elderly patients, children, suicidal patients. Why is it contraindicated in suicidal patients? Because we said it's very lethal when in overdose. Even in physically ill patients. Why? Because it can mask the symptoms of the illness. Patient is always drowsy and sedated. Then the SRIs, that's where we have the fluoxetine and our Zoloft, which is sertraline, which are the newest antidepressants, and they work by selectively inhibiting the reuptake of serotonin, and they have fewer side effects than the amitriptyline. So with fluoxetine, you can start at 20 milligrams, but for elderly people and kids, which are more than 12 years old, you can start at 10 milligrams. So, which means you cannot give for children less than 12. You can give up to 80 milligrams per day. Uh, you can give it if you don't want the patients to have sedation, if they are able to sleep on their own without a problem. And if they do not have, even if they have suicide ideas, you can give this one. It's not very lethal in overdose. You can also give it in the physically ill patients, patients who have HIV opportunistic infections, poorly controlled diabetes. Sertraline can also be given from 60 milligrams starting dose and increase gradually. Also, sertraline has the anti-anxiety effect at a lower dose than 50. So if you use it as a second line, you can use below 50 milligram dose or 50 milligram dose. So it cannot be used in pregnant women and breastfeeding women. It has got fewer side effects with less weight gain problem. It cannot change the seizure threshold, so it's safe in people with epilepsy. Even the anticholinergic effects are not a very big problem, although it is a problem because they are widely used, so we'll see a lot of them, of the anticholinergic effect in the clinic. They are much safer, but they cause nausea, diarrhea, tremors, these several side effects, which they subside within a short space of time. Then let's look at the special cases of children now younger than 12%. You don't use antidepressants, you just do the psychoeducation, you do the counseling. Then in pregnant women and breastfeeding mothers, we avoid them, but if you cannot avoid them, then you can use the amitriptyline. In patients who have major depressive disorder and suicide attempt or ideation, we avoid what? Amitriptyline. But can we give the others? MDD patients with suicide attempt or ideation. Can we give sertraline? Maybe, depending on the need. How big is the need? Yes. Depression with psychotic symptoms, two conditions coexisting. We give antidepressants and antipsychotics at the same time. For bipolar patients, we treat them with mood stabilizers and antipsychotics. And then when they are in the depressive phase of bipolar, we can add an antidepressant. And we monitor that. Once you see that mania is showing its symptoms, you can stop the antidepressant. So let's talk about the serotonin syndrome now. It's a condition that happens when you give SSRIs with another highly serotogenic drug. There are a lot of drugs which are serotogenic. Sometimes even when you give higher doses of SSRIs, you can see this life-threatening syndrome. So it shows up with symptoms like a change in the mental state. They start showing confusion, a dry mouth, sweating, fever, hypothermia, shock, sometimes nausea and diarrhea, tremors, muscle rigidity. It's a lot of symptoms because our patients will be mixing medication. So it's important for them to tell you if they are taking antidepressants. So it's very important now to see the effect of too much antidepressant in the system because it can cause a lot of problems to our patients. We can actually kill our patients. So many times they come confused and you'll say, it's just depression with some psychotic symptoms. Yet it's you who caused the problem. So it's important to understand this serotonin syndrome. So it's important also that when they appear in the clinic with these symptoms, you will have to give the anticholinergic medication and withdraw all those antidepressants. So you just discontinue those serotonin agents, you give supportive care, you monitor the vital signs, then you have to sedate them, especially when they are very restless. And then you can give serotonin antagonists, but they also have problems you have to monitor. So all these kind of symptoms, the patient will be complaining to you and you'll feel like, this one is suffering from everything. Let's talk also about the antidepressant withdrawal symptoms, which appear like flu-like symptoms. I think I saw a patient who has this yesterday. They've got sleeping troubles, insomnia, they've got anxiety, they are worried that maybe they are too sick now. They've got tingling sensations. Some they will say it feels like an electric shock. Their blood pressure would rise, they'll be sweating, tremors. Some they can even have seizures. So it's important to also note that when you prescribe antidepressants, there are drug interactions. You don't just give it anyhow. Be cautious when a patient is taking nevirapine, the anti-HIV medication, because it has an interaction with fluoxetine. Ritonavir increases levels of amitriptyline and Prozac. Darunavir decreases the level of sertraline, so you have to make sure you titrate correctly. And then you also have to be aware that carbamazepine and phenobarbital can reduce levels of amitriptyline. So when you prescribe them both, know that and titrate amitriptyline accordingly and even carbamazepine accordingly. In fact, you use a very low dose of amitriptyline. Then fluoxetine can also increase drug level of carbamazepine and phenytoin. So you can see a lot of side effects of carbamazepine and phenytoin when you use fluoxetine. Fluoxetine can also increase drug levels of warfarin and digoxin. So you can also see a lot of side effects in those cardiac patients. It's very important to also refer your patients for counseling when they are taking antidepressants. Thank you very much.
Thank you, Pharmacist.